Hello viewers, welcome to my YouTube channel. My name is John. You can call me the musical nurse. Alright, so today we want to talk about a disease condition called Cerebellopontine angle tumor, CPA tumor for short. Now CPA, let's talk about the CPA, that is cerebellopontine angle. Let's start with that first before we now talk about the tumor. Now the angle itself, where do we locate it? It's found in the brain. Now the brainstem, now let's come to the brainstem. In the brainstem, the angle is posterior to the what? The angle is posterior to the pyramid, is superior. No, let me know, it's superior is not the word now. Inferior to the tentorium, and is lateral to the pons, and is then there's another part. Then is ventral, guys. Yes, so it's a triangular space. So it's ventral, that is in front of the cerebellum. That is it. Exactly. So now let's talk about the CPA system. Like, what do we find inside this CPA angle? So in the CPA system, what we find there is cranial nerve 5 to 8. That is the trigeminal, the abducent, the vestibulocochlear, and so on. So those, the cranial nerve 5 to 8, those nerves, we find them in the CPA system. Now, below this CPA, we also have cranial nerves 9, 10, 11. Now, before you've been hearing cranial nerve. So let's not make this thing too difficult, okay? Alright, so let's even talk about these cranial nerves quickly, like briefly. What are these cranial nerves? Now, these cranial nerves, there are 12 in numbers. Let me list them from the top to the bottom. Now, starting from 1. Now, we have the olfactory, we have the optic, we have the oculomotor, we have the trochlear, we have the trigeminal, we have the abducent, we have the facial, we have the vestibulocochlear, we have the glossopharyngeal, we have the vagus, we have the accessory, and finally we now have hypoglossal nerve. And if you count it, we've listed 12 nerves. Now, other details about these nerves, you can see it from what we have here. So you can glance through it. So okay, now let's come back. Alright, so let's talk about the causes of this tumor. Now, the causes of this tumor is unknown. Yes, actually it's unknown. So, but there are significant risk factors for this tumor, and it's a genetic condition. This genetic condition is known as neurofibromatosis type 2, NF2. Now, this NF2, what it does is it causes this growth, this tumor growth on nerves. Yes, so it causes basically the nerve supplying the that is responsible for hearing and balancing, which is the vestibulocochlear nerve. Yes, so that's the part that this NF2 affects. So it affects the hearing and balancing. So that is the only thing that can predispose. They've not been any environmental factors that can actually lead to this condition aside this NF2. So that's that about the causes. Now we're going to talk about the pathophysiology of this condition. The pathophysiology of this condition is very simple. Once this genetic condition is present in an individual, now that neurofibromatosis type 2, that is NF2, it affects those nerves in the CPA system, that is cranial nerve 5 to 8. Now, causing this growth, primary benign tumor growth on nerves. Now, once this growth is noticed on the nerve, what happens is that those nerves, they lose their function, their normal function. So there's cranial nerve dysfunction. Now, this cranial nerve dysfunction is what now leads to the signs and symptoms that the patient will be presenting, like gait dysfunction, tinnitus, vertigo, headaches, and hearing loss, which is more prominent. So now we are done with pathophysiology. Now let's move to signs and symptoms. This patient will present with hearing loss, very, very obvious, and there will not be tinnitus, buzzing sounds in the ear. There will be vertigo. Now vertigo is unsteady, that is patient feeling off balance. There's gait dysfunction, gait in the sense like the way the patient walk. So there's a dysfunction in the walking step of the patient. There's gait dysfunction. There is a diplopia, double vision. Then there's facial hypesthesia, the patient feeling numbness or abnormal sensation, basically, and there will be cranial nerve dysfunction actually. So after that, these are the signs and symptoms that will be very obvious, or that will be obvious, the obvious ones. So after the signs and symptoms, we move to diagnosis. Now, how do we diagnose this patient? Is it that the patient will just come and just say, hey, madam or sir, you have cerebellopontine tumor? No, you can't just tell the patient like that. So we have to go through a lot of investigation. The patient will go through a lot of investigation before we conclude that, okay, this is it and this is that. Okay, so the diagnostic investigation, or how we diagnose this patient, is first of all, we take history, family history, to know if there's any genetic disorder, maybe hereditary. So go to get family history, occupational history, patient past medical history, and all that. Then we'll do physical examination. We examine the patient from head to toe and all that. Then we will now do audiometric and audiometric investigation and radiography. So that audiometric is the part that concerns hearing. They will also do MRI, which is magnetic resonance imaging. Then we'll also do what is called CT scan, computed tomography. Alright, so that is that about diagnosis. That is how diagnose this patient. So now, this patient that we diagnosed, so what next? We need to manage this patient. So how do we manage this patient? Medically, the patient can be managed by observation. Observation is done for patients that are maybe the elderly ones, and the tumor is not too obvious. The tumor growth rather is not too obvious. So what they will do is do scanning sometimes. So, but the disadvantage of this observation aspect is that the patient now is at greater risk of losing the some cranial nerve function. So what I mean by that is there is every possibility that the patient will end up with cranial nerve dysfunction. Why? Because of the delay in treatment. So the next management is radiation therapy. Now, radiation therapy is a surgery, is a surgical procedure. But the disadvantage of this radiation therapy, because there will be a lot of excision, there will be a lot of damage done to the cranial nerves that supply this area. So that's why radiation therapy will not be a best bet. Then after radiation therapy, we now have the microsurgery. Microsurgery is the best method, and is I think that is the best choice that the surgeon go for, and that is the best. That is the one that can give the best results. So in microsurgery, we have 3 steps. There's one that goes through translabyrinthine. That one is approach to the CPA tumor directly. That is, and there's middle fossa approach. That middle fossa aspect is for smaller tumor. When you discover that the tumor is not too big, it's small, then there's now retrosigmoid approach. That retrosigmoid approach is the one that is commonly used, right? Because now is the approach used when that tumor is dictated to be intracranially. So retrosigmoid approach is the one that is used frequently, like the best bet. Now that is that about the medical or the management. Now let's move to nursing management. Alright, so now we want to talk about the nursing management. Now, what will a nurse do in this condition? What's the role? First of all, we've discussed some of them, like the one that will take history. The nurse will take an history. They will do physical examination, like examine this patient from head to toe, that is head to toe assessments. And after that, of course, we need to admit this patient. This patient needs to be admitted for a proper care. The next thing we want to do is monitor vital signs. The vital signs of this patient, like the temperature, pressure, respiration, the respiratory circle, then the blood pressure, the oxygen saturation. So that's what I mean by vital signs. So vital signs. Then now we need to explain to this patient what this disease condition is all about. We need to make the patient understand the treatment regimen. We need to make the patient understand the prognosis, like what will be the outcome of all these things. So this is just to relieve and like make the patient less anxious. Yes, that is the word. Just to make the patient less anxious. Then after this, we give the patient psychological support because the patient needs it. It's going through a lot this time around. Because now the patient is thinking, okay, I'll soon be going for surgery. What is the outcome of this? So this time around, we need to reassure the patient. Okay, this will be this, this will be that. So that is basically our work before the patient goes for this surgery. And if there's any prescribed drug, that should be that. Then we'll do post-op management. That is post-op, like after the patient is done with surgery, when the patient is back. The first thing we do, we monitor the patient's vital signs to see that the patient is breathing at least, is alive, so the surgery has been successful. Then we will now check the incision site to make sure there is no abnormal drainage or abnormal blood coming out from that place. Yes, anything, just check for any abnormality. That is excessive. You can also check for excessive bleeding from that incision site. Then of course, we also give psychological support. There's never enough of it, so we give psychological support. We will also reassure patients. The patient, we also give prescribed drug as well. Give prescribed drug, and we position these patients in the position that will facilitate the drainage, and we try to give this patient enough fluids and allow this patient to rest. The patient needs to rest enough, and we also encourage the patient to participate in passive or active exercises. Yeah, just to help, so that because the cranial nerves are already affected. So this time around, we just want to try to is it kind of remind the brain that, okay, please, can you just come back to what it used to be before? It's not going to start all immediately. It will take all these little things like exercises and encouraging ambulation, like telling the patient to take a little sit up, stand up, move like this and all that, before all these functions of the cranial nerve can come back. It's going to take a while. So that is that about nursing management. Now let's talk about the complications of this condition. Now, okay, the patient have gone for surgery, everything has gone well, but sometimes the major cause of the surgery or the major reason for the surgery might be achieved though, but you see the way I sounded, but there might be a lot of complications, meaning that you solve one and there's from that one you solved another thing now came up. So what are the things that can, or what are the complications? Now, there can be hemorrhage, excessive bleeding. Yes, there can be cranial neuropathy. So meaning that what those cranial, okay, let me put it this way, cranial nerve neuropathy, meaning that nerves, remember we mentioned a lot of nerves that is involved in that CPA system. Some of them can get damaged and like damaged forever, meaning that that patient, there's no form of resuscitation. So that is it. And there are many other things. There can be CSF leak, that is cerebrospinal fluid leakage. There can be deaths. The patient can die from that surgery. There can be stroke. Yes, these are the complications. There can be headache. So the fact that we've removed this tumor does not stop the headache. So there can be headache and so many other complications. So how do we prevent this? Now there's no really because the cause is unknown. The only thing that can be done is we just avoid all this radioactive substance, because those are the things that predispose most people to all these tumors, all this cancer and all that. Radioactive substance. We should just be careful with all this radioactive substance, because that is the best advice that can be given. Then another thing again that I have to say is this. Now this time is not the prevention, the prognosis. The prognosis of cerebellopontine angle tumor is good if it is treated early. And again, it also depends on the size, the consistency of the tumor. That's what determines the prognosis. Now what I mean by prognosis is like the outcome. The outcomes. Let me just put it that way in simpler thing. So in summary, what am I saying? Cerebellopontine angle tumor is a tumor that affects a part of the brain, that is the cerebellopontine angle, and there are various types of it. The most common one is vestibular schwannoma. The vestibular schwannoma or acoustic neuroma. For the word vestibular schwannoma, you will know that it's affecting the what? It is affecting the vestibulocochlear nerve, and you know that it's going to be responsible for hearing loss. So there are other, after vestibular schwannoma, we now have meningioma. Then after meningioma, we have epidermal and other ones. The meningioma, how do you differentiate between meningioma and vestibular schwannoma? The basic difference is that meningioma, there's more of headaches, then vestibular schwannoma is more of hearing loss. So it's hearing loss that differentiates vestibular schwannoma from meningioma. Meningioma, the hearing loss, but the headache is more obvious in meningioma. Okay, so that will be that about the presentation on cerebellopontine angle tumor. I hope you enjoyed this video. Please like and subscribe to my YouTube channel. And if there's any question, let me know in the comment section below. So I'll be waiting for your comments, your contributions, and please don't forget to like and subscribe to my channel. Thank you. See you some other time.